very important. Your brain should be in charge, not AI. And don't believe it, whatever it says. We are having, I was discussing the process, we are having the same problem because I'm integrating AI in our diabetes screening program and we're getting lots of wrong information.
I was trying to develop a talk on AI and I delivered a talk, and one of the slides which I got was the NHS is real field testing AI-driven diabetic retinopathy classification. So probably you're referring to that.
Absolutely. Because we got just at this cusp of making redundancies for screeners and graders because we thought this system is perfect. But then we picked up problems. So it is coming, but it's not perfect. So be careful, even the watch out. Right, diabetic retinopathy. My name is Shweta Chaudhary. I'm a consultant ophthalmologist and medical retina specialist and clinical lead for the screening program in Greater Manchester area. So we are looking after more than 200,000 patients. So there's a very sort of scenario how we are tackling this retinopathy epidemic. The scale, I think you are already aware. We have around 366 million diabetics globally, and about 191 million are expected to be by 2030. Threatening diabetic retinopathy is expected to be 56.3 million by 2030, and leading cause of blindness in a working population. This is very important because financial burden on any nation, you can imagine what will happen. And in the recent years, the macrovascular mortality has improved with the better management of diabetes. We have got now lots of systems in place controlling diabetic control. These are CGMs, hybrid loop systems, automatic pumps are being integrated now. And we have got the GLP-1 and those glycosuria called SGLT1 tablets available. So they are controlling diabetes in that way, but it is only improving your macrovascular complications, not microvascular yet. But that is the next frontier. I think hopefully there's a lot of work going on how to control vascular occlusion and sclerosis. And hopefully there should be good news coming in a few years from that front as well. But in that time, we have to manage what we have at the moment. So there are about 35 population-based studies, which are telling the prevalence among diabetics. The diabetic retinopathy is around 34.6%. Proliferative diabetic retinopathy is around 7%, and diabetic macular edema is 6.8%, and threatening diabetic retinopathy is around 10.2%. This is global population data. This is important, I think, for you people to know developed versus developing countries. In the developed countries, this data is mainly from type 1 diabetes. The incidence is decreasing, so they are controlling it now from 3.4 to 1.4% at the moment in 2025. Diabetic macular edema incidence is decreasing as well, from 1 to 0.4%. And basically, it is the better blood sugar control which is being achieved at the moment. So we are gradually winning. For type 2 diabetes, we don't have the data available yet, but it will be available soon as well. Now the risk factors, these are all well known. I will just give you a bit of introduction to it as an ophthalmologist. When you are managing that retinopathy, what else you can do to improve the outcome. So it is hyperglycemia is well known, hypertension is well known now. There are many studies. They affect diabetic retinopathy if people have hypertension. Dyslipidemias, and duration of diabetes, pregnancy, puberty, and cataract surgery. So these are, I think, all you are all aware of these sectors. Now, financial cost. In the Western world, 11.6% of the healthcare budget is spent on management of diabetic retinopathy, which is a huge amount. In USA alone, it is $490 million in 2004. It must have gone up way above this in 2025. In Sweden, per patient, they are spending about $93.6 just for diabetic retinopathy screening, and $334 for proliferative diabetic retinopathy, and $280 for diabetic macular edema management alone. So you can, if you want to convert into local currency, what is the sort of scale of this problem we are facing. In Pakistan, I think you know, Pakistan is the #1 center for diabetes mellitus in the world. So this is a record. More than 30% of young population is diabetic. It's a Atlantic and Middle East. I thought Middle East was worse, but we are. And yeah, it is 31.5%. And it was 34.5 million people in 2025. By 2050, it will be 70 million. And provincial division is also very interesting. Sindh is 32%, Balochistan is 29%, Punjab is doing better, 16%, and KPK is around 13%. So diabetic retinopathy incidence is around 24 to 28%. That means around 9.6 million people. And total cost to manage diabetic retinopathy is running around $2.7 billion in this country. So the resources available to you, you can imagine how important it is to have preventive treatment rather than treating the problem when it happens. And vision-threatening diabetic retinopathy in Pakistan, 1 in 10 adults have diabetes mellitus, and 27% are undiagnosed. So they develop problems without knowing it, and we don't have any system in place to pick those people up at the moment. Approximately it is 5 to 7 million people, and annual cost, as I mentioned, is around $2.7 billion. For Pakistan, important thing is mass screening we have to do. I am lucky I'm involved in some other parts in screening program in Pakistan. One of them is the breast screening through Cancer Care Hospital. So I have got some ideas how this can be applied in this country where we don't have any well-established system of screening. So hopefully that should work. So important thing is we need to train non-medical workforce to pick up diabetic screening, diabetic pathologies rather than delegate everything to the specialists, because the scale is huge. So this is what we have done in England in the last 20, 30 years, and I think we need to develop that in this country as well. Very important, simple as well, from these pictures, and to grade the diabetic retinopathy by these non-medical personnel, and then refer to HES who needs to be referred. So I think in the morning talk I gave you some outline of diabetic retinopathy levels, where these screeners and graders can grade which needs to be referred to a consultant or a specialist and which can be followed locally. And now with the technology, with telemedicine, with all these things, I think it is important that we train non-medical people. They should know how to take pictures with the smartphones, or if there is an access to OCT, or if you have mobile vans with OCTs in it, so you can take pictures and pick up those people who needs to be seen urgently and treated before they go blind. I was listening this morning, many speakers were saying they have patients, by the time they come to you, they have traction retinal detachment. So that battle is already lost. Even if you do VR or whatever, but functionally, it is a lost case. So we need to pick them up. With the breast screening program, I was very impressed that they have when they go into inner areas in the Sindh and Kashmir in the northern areas, and they have picked up more than 5,000 suspicious cancer patients, breast cancer patients from the villages, and they have treated them in time rather than catching them when they have secondaries or when they are stage 4 and the process maybe they will be dead. So I think we need to think on those lines in diabetic screening as well. Now, there has been some shift in the medical management of diabetes from retinopathy from ophthalmological point of view in the last year, and NHS England have revised their guidelines, and they have given new protocols for the ophthalmologists to follow, which are very interesting. So we are not only just doing now lasers and operations and injections, there's more you can do to manage this. So these guidelines, who are the people? Secondary care professionals like ophthalmologists, ophthalmology practitioners, and patients and their families. They should be involved in it, in the management. And the recommendations are that you should work with the person, spend some time, and just make them realize what is the problem. It is not standalone eye problem. There is a general problem going on in the body, and if they manage that, you can manage their eye condition as well. So I think we have to think a bit more generally how to manage it. And obviously, long-term management, diabetes mellitus type 2 and type 1 in children and in pregnancy. So all these people, we need to cater for. It's not only just anybody coming in, okay, we will give you 3 injections and see you in 4 months' time. That is not enough. And you are aware of this now with the Ozempic, Mounjaro, and all these fancy medications coming up, rapid reduction of hemoglobin A1C will cause diabetic retinopathy problems. So you need to see those patients before they are started on treatment and then follow them up to see, it is just like type 1 diabetes or in pregnancy. Rapid reduction can cause complications. So you have to be very well aware of that. And I think there's a pandemic going on of injection due to weight reduction management going on. Lots of those people are diabetic, which is undiagnosed. So they will suddenly get problem with their eyes. So you have to work with endocrinologists or anybody who is managing their weight and all those things so that they don't get into this pitfall and lose their eyesight in the process. And so we have got protocols already in place there. Any patient who is started on a rapid weight reduction program and is diabetic is first seen by the ophthalmologist or at least have a diabetic screening done in the community. And once they get it all clear from us, then they will start these injections. What you need to do, we need to know the level of HbA1c when you see the patient in hospital service. We need to know the blood pressure results, and we need to discuss this with the patient. Many of them, they are hypertensive, but they are not taking any medication. The reason is nobody checks the blood pressure, or if they do, it's just one reading somewhere, and it is normal. Well, that is not enough. You need to have a data in front of you, because hypertension is now one well-known predisposing factor for diabetic retinopathy progression. It's not only diabetes at all. And so we need to discuss with the patient and make them aware And similarly, obviously, you tell them if it's not controlled, what will happen. And decision making for intervention is obviously we need to stage diabetic retinopathy at what stage they are. Some of them will just need follow-up and then better diabetic management guide rather than anything else. So I think spend some time. The problem is endocrinologists and other people, they don't explain this to the patient. Typical Western medicine, we believe in treatment, just offer the tablets, injection or whatever, and then patient goes away, but they don't know it's a lifelong treatment. Disease of abundance basically, and so we need to have a diet guidelines. We need to have the guidelines, the quality of life, and how they should manage all this chemicals. Otherwise, it doesn't work. HbA1c level, we need to know renal function and blood pressure. These things, ophthalmologists need to know as well before offering any treatment. Now, blood pressure management, it is well known, can reduce the progression of non-proliferative diabetic retinopathy. Obviously, we don't offer blood pressure treatment, medication without hypertension, just for non-proliferative diabetic retinopathy, but do convey to your physician that this is what's happening. So they are kept at least under observation, if nothing else. Phenofibrate is a new kid on the block. It has been shown to prevent or reduce the progression of diabetic retinopathy. The problem in England is that it is off-label medication. It's not approved for treatment of diabetic retinopathy yet. So what we are doing is asking the GPs and their endocrinologists if they can prescribe this medication to the patients who have developed non-proliferative retinopathy. So this is one thing that people can also take note of if it is possible. Statins at the moment, there's a very strong sort of evidence, but we haven't got any double-blind trials to say that this has an effect in reducing the proliferative and non-proliferative diabetic retinopathy progression. But I have a feeling it will be the next one that you will be advised to prescribe to the patients or ask their physicians to consider using that as well. So there are different modalities coming on your way apart from other things to manage retinopathy. Cataract is well known, all of you know it makes it worse, so you need to manage that before doing cataract surgery. And post-op cataract, you can use topical steroids and non-steroidal anti-inflammatories to prevent diabetic retinopathy. So this should be actually part of your post-op regime in all diabetic patients who are having cataract surgery, rather than waiting for them to do anti-VEGF has a very limited role, but it can be used in dense cataracts, which is including any pan-retinal photocoagulation. So it can be used as a temporary measure till you can do the cataract surgery and then manage retinopathy accordingly. These are the protocols which we use, that if patient has moderate to severe non-proliferative retinopathy and they are not on any treatment, we usually see them in 6 months to 12 months time. And if they are severe, then 3 to 6 months time to follow them up and see what needs to be done. Well, this is just the flow chart of the thing that we have discussed. Proliferative diabetic retinopathy. Obviously, first is the correct diagnosis. There are pitfalls, so not everybody needs treatment. And secondly, you need to discuss with the patient various options are available. You can do PRP, anti-VEGF, or even no treatment. If it is safe, the proliferative retinopathy does become stable with time. And if they can manage the patient properly, their diabetic control improves, blood pressure improves, their cholesterol things improve, and for some reason, if you don't want to do it, then you can follow the patient. It does become stabilized over time. So it's not everybody is going to go blind. It's a very small proportion, but it is. And some people do make a decision to discuss with them. And obviously, if you are going to treat, PRP is the first line of treatment, and we tend to do within the first 4 weeks to do the retinal photocoagulation and finish it off within 4 weeks if possible. I don't know here how it is done, but we have the same, yeah. Similarly, same-day treatment in certain patients if they cannot come for the second 2 weeks or 3 weeks time. So we have arrangement to do it on the same day once it is diagnosed.
If you permit, this is one of the specific questions which I was on behalf of the Medical Retina Association guidelines, which are well targeted. We have actually developed guidelines in 2012. They are on the net.
Yeah.
In that, the expert group actually recommended that people who come from far off their flung area to California, you can actually give 1,000 single PRP session.
Yeah.
So that is something which we need to put in our guidelines. Now, how do we go about it and what would be the intensity number? Of course, it will be standard, but if you go to the literature, we won't be able to find single session PRP. So we can have our real life evidence.
Absolutely, absolutely. Now, anti-VEGF, obviously PRP is the first choice, but for some reason, if you want to try anti-VEGF, ranibizumab is the only licensed medication at the moment. Similarly, vitreoretinal, if there is a traction detachment, you can, if there is no threatened retinal detachment due to traction, you can always watch. But if it is progressive, then obviously you have to operate. We just give anti-VEGF if there is a vitreous hemorrhage, and it prevents proliferative diabetic retinopathy. So we just do it as an interim measure, so that as soon as the view is clear, you can go and do the PRP. Or the other is if PRP is not possible, then you cataract is another reason. So PRP should still be the first line of treatment and the treatment of choice. Vitrectomy, again, if there's a persistent vitreous hemorrhage and it has not cleared in 3 months, then vitrectomy we consider. If there's a macula threatening retinal detachment, or if there's an active proliferative diabetic retinopathy even after end-retinal photocoagulation, then you can go for this. Or there's a recurring vitreous hemorrhage due to proliferative diabetic retinopathy or vitreomacular traction. So these are the indications. Once you have done all this, so how do you follow them up? We do ultra-wide field imaging, plus obviously clinical examination and OCT. Post-treatment, completion of treatment, we watch them every 2 to 3 months for the first year. And they are followed up for at least a year in hospitalized service. And then we can discharge them back if they are stable. But some of the patients, they are not suitable for community screening, so we just watch them in hospitalized service. So obviously you have seen these pictures, wide field photography is making a lot of difference in the community screening of diabetic retinopathy. This is a flow chart for what we have discussed already. For diabetic macular edema, again, we discuss with the patients. The options are anti-VEGF, which is number one treatment, macular laser, very limited in my practice at the moment, steroid treatment, or just observation. This is only my clinical impression. I haven't got any data to prove that, but I have got many patients in whom I have given them good lifestyle advice, dietary advice. They had macular edema, vision was reasonable, and their central retinal thickness was not up to level where we could give them injections. And they have come back within 3 to 4 months, and central retinal thickness has decreased, which is something new I was not aware. So spending some time with your patients and explaining to them what is diabetes and how can you manage it and how can you control it. Because if the diabetic load is there, no matter what you do, it will keep on getting worse and worse. Leakage will happen. So this is important to spend a few minutes and tell them, cut down on your starchy foods apart from sugar and potatoes and rice, which is a staple diet, and see what happens. And they are very, I would say, not resistant, very conducive to your advice which you give them. And unfortunately, I was talking to my endocrinologist colleagues. There is no such advice available. They do exactly what we used to do. Okay, have the PRP or have the injection and that's it. But I think we need to sort of concentrate on those aspects as well. Non-center involvement, this is something new. If it's a succinate types, obviously you can do the laser treatment. But if there are multiple succinates and if they're pretty much progressing, then there is a question what you should do. You should give injection or depending upon the retinal thickness and the visual acuity, there are 2 parameters we use to decide what you want to do. Grid laser has decreased considerably in the recent years, and I tend to avoid if I can. Go for the injection if you can. And there are studies that while Bismo is statistically quite effective comparing to the IV and other anti-VEGF treatments. So I usually go for it if I have to go for injections. If it's a center involving DMO and the vein is good, that is 79 letters and better. So I discuss with the patients that you want to go for observation or you want to have laser treatment. The majority of patients they opt for observation. And then I give them the diabetic and general advice, which helps. And usually they are very helpful in that regard. But if central retinal thickness is 400 microns or above, then we go for anti-VEGF injections. Now, this is one cohort of patients in which the vision is impaired, but retinal thickness is less than 400 micron. So what to do? But nowadays, NHS England has given us discretion that you can go for laser or anti-VEGF if you need to. You don't have to wait for their thickness to go to 400 micron. If the vision is affected, then you can stop the treatment. So visual acuity is also important when you are assessing what sort of treatment to offer to the patient. Once you have done that, you can do laser as an adjuvant treatment if need be, if there is still residual macular edema present. But if it is stable, we usually tend to see them after 12 months, and if the response is suboptimal, steroid implant is the next option you can go for. Sometimes the patients don't want to continue with anti-VEGF, so you can put a steroid implant. The long term, the one which you use is effective for 2 years. Means you don't mind UV if you have injected. After the treatment, again, we follow them up with the OCTs, and if they are stable after 12 months, we refer them back to the community screening program so they can be followed up there every 3 months or 6 months. And if they are not suitable for community screening, then we watch them every 12 months in our clinics. So this is just a flow chart. Now, if the DMO is not responding after all these treatments, then we review our diagnosis as well, that it may well be they have a retinal contraction of the contact membrane. It may be the underlying reason rather than diabetes itself. The resource impact, this is from NHS human advice. 95,000 people they lose sight in England in spite of all this. And there are 1,280 new cases of blindness per year in England alone. And for 4,200 per year impairment. We have a system where we register patients who have got impaired vision. CPR registration it is called. So we have data of these patients. The new recommendations, just in summary now, one is a phenofibrate is the medication available. Central volume DMO with good VN that is less than 400 microns, you can still go ahead and treat. And if central involving DMO with poor VN and CRT is less than 400 microns, we need to treat that as well. Phenofibrate, as I said, it reduces the progression. There's a double-blind trials available. And in England, we think around 1 million people are eligible for this treatment.
How much does it cost?
They have come up with around 10,000 people, it will add 400,000 pounds cost. For any population-wise, it's not very expensive medication. I exactly don't know the cost. But
Just roughly.
maybe 5 to 5 something like this.
It's not very expensive.
No, it's not. And it's freely available. The only problem is it is not, the company has not authorized it for use in the physicians are using off-label.
Like a Western.
Yeah,
So is it in a tablet form or injection?
tablets.
And how many times a day is supposed to be?
Often I don't know. I think probably twice a day. But usually it's I refer to the physician.
And you are using in NHS patients?
Yeah.
Okay.
These are used for triglycerides, I think.
Yeah.
So if treatment set is useful, is a triglyceride. So will it affect the patient lipid profile as well?
It should. Probably that is the way it affects. But we don't have the data available with the statins to say that they definitely reduce the diabetic retinopathy. So once that becomes available, probably then maybe a year or 2 years time we will have those results.
Is it available in Pakistan?
Yes, really.
Probably I think you'll be working on the lipid exhibition in the
They have a phenotype.
Yeah.
In Pakistan.
Probably this is what it is. Yeah.
the heart accident.
Yeah. So these are just the numbers, the NHS things. Their estimated number is around 75,000 people will need further treatment with injections. But over a period of 5 years, they reckon the number of injections should go down in such patients. The expected benefits from these new guidelines are that it should slow down the rate of retinopathy, reduce the time and cost of additional treatments, and better pre-op and follow-up care will reduce the risk of future complications, and better health outcome and care experience. Our responsibility, these are the guidelines. Obviously, there will be individual needs, and you have to respect patients' values and preferences. Now, guidelines are guidelines, they are not mandatory. At the end of the day, you are responsible. You have to make a decision. So this is basically for the preventive medicine doctors to take into account health equality, reduce the health inequality, provide equal opportunities for the patients to access the services and benefit, which obviously in this country is still very difficult. Funding is the other issue. Terminology we are aware of, so I won't go into that. OCT examples we know. This is proliferative diabetic retinopathy. Permanent damage, when do you diagnose? When there is a photoreceptor loss, you can pick it up on OCTs or macular atrophy and another macular holes. This is a basically lost case. There's not much you can offer. So our job is to get these patients before they reach to that stage. Macular holes, aware of. Vision impairment, we class as 78 letters or less, Snellen 6 over 9 or worse. This is vision impairment definition, the definition. So thank you very much. So a quick run through diabetic retinopathy and when to discharge them back to the community. So I think for us, the most important thing is to develop some sort of screening mechanism. In bigger cities, probably where people have practices, some practitioners, you can train them. So maybe that will reduce the burden.
What sort of a resource technical